Okay, everyone, thanks for coming back. We've got our last, but certainly not our least presenter. So our last session before Scott's wrap up and a bit of networking after that is pharmacotherapy, a consumer perspective. So I'll just talk a little bit about our presenter. So Sarah Lord, she's the program manager of the Pharmacotherapy, Advocacy, Mediation and Support Service, which most of you, I hope, would be aware of, also referred to as PAMS, and they're based at Harm Reduction, Victoria. Sarah's worked in pharmacotherapy and with opioid-dependent people for over 25 years. She's got a diploma in AOD work and is committed to harm reduction and social justice. For anyone who hasn't used PAMS before, I've used it on a couple of occasions. I'm based in the emergency department in Bendigo, and I've found it to be a brilliant resource. Just because we have such limited services as far as pharmacotherapy in Bendigo. So we have very few community prescribers. We've actually lost a few really good prescribers. We will often have trouble. People will present to ED because they don't know where else to go. Our pharmacotherapy service through our community health centre is incredibly busy and find it very hard to take on new patients. So when I have been needing to use this service, I found it's been really good to actually source pharmacotherapy options for our patients and to sort of advocate on their behalf to sort of make sure that it can happen and get established in a smooth sort of manner. So if everyone wants to put their hands together, Sarah's going to keep us entertained for the next 45 minutes.
Hopefully. Thank you, Daniel. Hi, everybody. I would like to acknowledge the traditional owners of the land in which we're meeting today and their elders past and present, and also acknowledge anyone from an Aboriginal and or Torres Strait Islander background who might be attending today. So I'm happy to do this as informally as possible. So just interrupt me, ask questions, make comments. Yeah, by all means. Okay, hopefully this will work. Whoops. Good one. Okay, so off to a roaring start. Okay, so just basically what we're going to cover is a bit of background about pharmacotherapy in Victoria, because Victoria does have a little bit of a different pharmacotherapy service delivery system compared to some of the other Australian jurisdictions. I'll tell you about the PAMS service. Basically, I always tell everybody about the PAMS service, where we came from, who we are and what we do. We will look at a bit of the PAMS data, some of the consumer issues, provider issues, some of the systemic work that we do, some of the roles for nurses in alcohol and other drug work, how we could possibly improve the Victorian pharmacotherapy system, and if time permits, I'll drag you all through a PAMS case study, but we'll see how we go. Okay. So Victoria is probably one of the only Australian jurisdictions that relies almost solely on a community model of service delivery. And the purpose of this is to normalise pharmacotherapy treatment, to reduce stigma associated with opioid dependence. So people are seen by community prescribers, so that's general practitioners and more recently nurse practitioners, and dosed in community pharmacy. There are also 5 SPSs or specialist pharmacotherapy services around Victoria. Most of them, unfortunately, are, or in fact, actually all are in the metro areas, which is a bit unfortunate, but that is something that we're looking at. And the SPSs are funded to prescribe for people who have multiple complexities, so opioid dependence and other issues. The program is overseen by a set of guidelines, and they've been developed by a team of experts and updated sort of at certain points. Like, for example, the guidelines were updated during COVID, and more recently to incorporate the long-acting injectable buprenorphine. So PAMS is a program of Harm Reduction Victoria, which is Victoria's only funded peer-driven and managed drug user organisation. PAMS has been funded by the Victorian Department of Health since 2001. So PAMS, what used to be called Rave Safe, which is now DanceWise, and the Drug Overdose Prevention Program, they were all funded in 2001. The PAMS service operates via a statewide 1-800 number, which is a free call from any landline, any public phone, and most mobile phones. We've really got two broad goals. One is to assist people who are already on a pharmacotherapy program to resolve any sort of program-related problem or concern that, if it wasn't resolved, is going to result in the person doing, badly in treatment, or worst case scenario, dropping out of treatment altogether. And these sorts of program-related problems can include issues relating to takeaway doses, not getting enough, not too many takeaways is not usually a problem, but not getting enough, arranging intra and interstate transfers for people, assisting to negotiate treatment plans and treatment agreements, even supporting people to exit pharmacotherapy, reduce their dose, that sort of thing. Our other primary goal is to support people to access, so that's to start or restart a pharmacotherapy program. And that's particularly anyone who's having trouble doing that on their own. And much of this work is actually about matching the consumer with the service provider. So we don't just say, look, there's a number, see you later. We find out, where people are living, do they have transport, what are their needs, have they been on program before? If so, what sort of treatment have they been on? Did it work? That sort of stuff. And we really try and, as best we can, match people to a prescriber and a pharmacy as well, if that's required. It's all on the basis that if you can set up a really good relationship between the consumer and the service provider from the get-go, then you've got someone who's much more likely to remain in treatment for the longer term, as opposed to sort of say, oh, look, that just didn't work, and then drop out. These are long-term programs, and the longer people are retained in treatment, generally evidence indicates the better the outcomes that we get. Oops. So the idea for the PAMS service actually came from a conversation from a small group of people that were on methadone. It was only had methadone back in the mid to late, probably late 80s, early to end of the 90s. Essentially, the group felt that there were a number of ways that life on methadone could be improved. They had a number of concerns that weren't quite sort of severe enough to make a formal complaint, and therefore direct those concerns to the formal complaints bodies. But there was essentially a strong need for an independent, consumer-friendly, non-judgmental sort of pharmacotherapy-specific service that people could access pretty easily, where they could get accurate peer-based information, request advocacy and mediation, vent their frustrations, and seek support. This led VivAIDS, which is the original name for what is now Harm Reduction Victoria, to undertake a research project which looked at these problems, issues, and concerns. And that 12 months worth of research got us the Methadone Advice and Complaints Resolution Service, MACS. And that first 12 months of MACS was actually funded as part of the buprenorphine, LAM, and slow-release oral morphine trials that were run by Turning Point in the early 2000s. We were originally MACS, then we were PACS, and now we're PAMS. So we've kind of changed over the years. We found that having the word complaint in our name caused a real problem. And as soon as we said, hi, my name's Sarah, I'm from the Methadone Advice and Complaints Resolution Service, instantly you had service providers on the back foot, and the response was, okay, who's complaining about me? What's the problem? And we have no powers of enforcement. And we were never a complaints body. It was really not about complaints. So we've, as much as possible, tried to sort of mould the PAMS service in direct response to the needs of the consumer group. I guess what we really do now is consumer-driven, short-term, solution-focused pharmacotherapy case management. So we might actually only work with someone for a few hours of a day, but we also might work with them for 3-5 days, a week, 2 weeks, or even a month or more in some cases, depending on what the issue is. So the PAMS staff. So being a program of harm reduction Victoria, the PAMS staff often, but not necessarily, have a pharmacotherapy and or opioid dependence experience personally or through family members. And I guess it's like other services of Harm Reduction Victoria, peers supported by Harm Reduction Victoria and bring a unique perspective and personal insight to the role. They easily develop trust and rapport with PAMS service users and have a credibility that is really often felt rather than expressed. So if someone I'm working with, for example, says to me, "Oh, look, you just get it." Honestly, that's really the best compliment anyone could say. So it doesn't have to be said. It's just literally a thing that people just kind of know. We've now got 4 staff at PAMS, which is really huge for us. For many, many years, I was the only worker at the PAMS service, and then there was me and another 3-day-a-week worker. So we've now got myself full-time and 3 staff that are 3 or 4 days a week, which is awesome. And I always had this sort of theory that as soon as we get more staff, I'll be heaps more free and I'll have heaps more time, but no. Not how it's turned out. That was a real learning curve for me. So some of the PAMS data. So this is data from the 22-23 financial year. So in terms of whether our service users have ever contacted PAMS before, we've got roughly 60% new to the service. And so that's never, ever have contacted the service in the entire existence, as opposed to just not contacted us in the last year. And about 40% of our service users have have called us before. About 70% of our service users are metro-based, so they reside in metro areas, and about 30% are regional. And that's about the split of where the pharmacotherapy consumer group actually reside in Victoria. The average age is 42, minimum was nearly 19, and the oldest person that we had in this period was nearly 73 and a half. 66% of our service users are male, nearly 34% female, and just less than 0.5% transgender. 73.3% of our service users are unemployed, and just under 20% are employed. Now that's part-time, full-time, casual sort of employment. Quite a lot of our service users are actually homeless or at risk of homelessness, and that's 7.7% of the total consumer group. One of the things that we do keep a track of is who the issues relate to. So, for example, somebody might ring us and say that they've got a problem with their prescriber, or they may have a problem that relates to their pharmacotherapy dosing point, the pharmacy, or it might be both. Interestingly, previous sort of like going back sort of 5-10-ish years, most of the problems all related to dosing in community pharmacy. That has totally flipped, and now 47.5% of all our cases related to a prescriber issue alone. 26% was pharmacy, and 25% of cases related to both. And I think that really demonstrates the growing number of not enough doctors, which is becoming a huge problem. Some of the treatment data, what I find really fascinating about the PAMS data is that compared to like the 15,000 people on program Victoria, we work with roughly 1,000, we sort of do roughly 1,000 cases per annum. So that's not 1,000 individuals, because there are some people who may contact us more than once during a financial year. But this data is really reflective of the national data, the national NOPSAD data, which just in terms of like gender, treatment type, age, all of that stuff. So in relation to treatment, what you need to remember is that some people are not on a program when they contact us. So this data set in relation to treatment, it's what people are currently prescribed, but it also gives an idea of what people are currently wanting. So somebody might ring us or contact us and say, I really want to restart or start on methadone or the long-acting injectable buprenorphine, or they may already be on it and have a problem. So 51.5% of people were on or wanting to start or restart on methadone, which compared to 56% last year. That is really interesting because there seems to be a growing reluctance amongst a lot of the prescribers to start and restart people on methadone, which I think is a pity. But anyway, Suboxone or buprenorphine naloxone combination, so the Suboxone film, which many of you have heard of, 30.6% this year compared to 33% last year. The buprenorphine mono formulation, so the Subutex tablets, was 3% this year compared to 1.5% last year. And I was thinking, when I saw that, I was like, what? Hang on, how come that's increased? But there could be a number of reasons for that. There was a couple of prescribers that ceased prescribing who had a reasonable number of people that they were prescribing Subutex tablets to. It could be that, or it could be that perhaps we had more people getting off Suboxone or buprenorphine in that 12 months. So according to the Victorian guidelines, if you're getting off the long-acting injectable buprenorphine or off Suboxone and your daily dose amount is less than 2 milligrams a day, it's quite fine for the prescriber to give you Subutex tablets because they come in a 0.4 milligram formulation. So you can do quite low sort of dose reductions. In terms of the long-acting injectable buprenorphine, we've got Buvidal, and that was about 10% of the PAMS service users. And then Sublocade has increased from 5% to 5% this year from 3.2% in the previous year. In terms of whether people are actually on program when they contact PAMS, 76.5% are in treatment and just over 23% were wanting to start or restart or start for the first time. One of the biggest challenges that I've actually noticed over the last sort of 5 to 10 years is who the pharmacotherapy consumer group is. So traditionally it was all injecting heroin users or people that were using opioids sourced through the illicit market. However, not so more. I mean, yes, there is always that group, but what we're finding more and more is that people have never sourced a drug through the illicit black market, never injected a drug, are now on pharmacotherapy because they were quite often prescribed SA opioid analgesics for the management of chronic pain. And, you know, pain dependence, it's often people have been on opioids for many, many years. Sometimes a prescriber will retire or stop prescribing and that person cannot find another prescriber to continue the medication they were on. But yeah, this is definitely one of the changes that I've noticed. And there's a very big push to get people off prescription opioids. So that's also contributing. Where are we up to? Okay, so we worked with 83.2 cases a month. We're sort of funded for about 70. So the demand is definitely there. Just over 86% of our service users were still on a program or in pharmacotherapy treatment at the point of last contact with PAMS. So in relation to the impact of our service on access to treatment and treatment retention, almost 75% of the people that we worked with were retained on their current program as a result of assistance from the PAMS staff. 17% restarted and 4.5% started program for the first time. And it's actually quite a lot of work to get someone to the point of actually starting pharmacotherapy treatment, particularly if people have been dependent on prescription opioids, and that's really would be their preferred choice of medication if they could continue on it. People do often present to the PAMS service with multiple issues. One of the things that we do is identify what's the primary issue or the most pressing concern, and then the associated primary outcome for each case. In this last 12-month period, the most commonly reported primary issue was payment and debt management at community pharmacy at 16.5% of all cases. Trouble accessing a new prescriber as the current prescriber had either retired or moved on at 15.5%, and trouble sourcing both a prescriber and a pharmacy at just over 10%. So the most commonly reported primary outcomes was us finding a new prescriber at just under 30% of all our cases, followed by the provision of a small amount of financial assistance at just under 14% of all cases, and finding a new prescriber and a dosing point in 9%. So, okay. So some of the consumer issues, definitely cost of treatment in community pharmacy was a huge, huge, huge issue until 1st of July 2023. And I'll talk a bit more about that as we move on. Choice of treatment type is an ongoing issue. As I alluded to before, it is getting difficult to start or restart methadone. There are some clinics that just say, no, if anybody is coming here and they're not a current client and not already in treatment, we won't restart or start anyone on methadone, which is a little concerning. And I guess where we're coming from at PAMS is that treatment needs to be it needs to be the right treatment, the right dose, delivered in the right way by the right people in at the right time in the person's life. And it really needs, as much as possible, to be kind of steered by the person who's opioid dependent. I mean, I've literally seen treatment for opioid dependence like literally not work if it's been the type of treatment that the person is not wanting or not requesting. We have an increasing number of particularly some of the high volume prescribers in Victoria are unfortunately reaching their retirement age and leaving the field. And unfortunately, general practice, and then you get a sort of niche area like pharmacotherapy, for whatever reason, is not as attractive as what it has been many years ago. And we're really struggling to keep, retain, and attract prescribers to this field of medicine. And it's a really big problem. So this results in people having to travel considerable distances or having to wait substantial amounts of time before we can actually get an appointment for people with a prescriber. Travel and employment can also be difficult to manage for people who are on pharmacotherapy treatment, and everything that we do is impacted by stigma and discrimination. It just literally creeps in at all different aspects of treatment. I think it does for the providers too, though. So some of the issues for providers, access to training and support is something that we hear frequently. The perception of the consumer group. So unfortunately, people who are opioid dependent are often seen as a very aberrant, difficult bunch, which is really not the case. I mean, usually when you sit down and talk to any prescriber or pharmacist, they will usually say, 98% of everybody that we work with is absolutely wonderful, but it would be that one person, that one incident that you saw or heard about. That's the incident you remember, and that really colours people's views and perceptions of others, and it's really difficult stuff to challenge, to the point that when somebody who's on, say, the methadone program or Suboxone, if they present at the ED, many people are just fearful to say, look, I'm actually on a methadone program, and people have reported back to us that as soon as that they let nursing staff or doctors in hospitals know that they're on methadone, that's it. They're instantly judged as drug seeking. And I mean, really, who would go to a hospital to get drugs if you're already on like methadone or Suboxone? It's just something that I don't think happens as much as what some stuff possibly perceive that it does or could or would. Providers often say to us that they feel that there's a lack of collegial support, system support. There is an aging prescriber workforce, as I've said. Referrals for people, say, for example, who are homeless or who have multiple issues such as opioid dependence and mental health issues can be really difficult for a prescriber to manage, a solo prescriber to manage in general practice, and particularly in a sort of like a 10 or a 15-minute appointment. Access to specialists, be they addiction medicine specialists, pain management specialists, and psychiatrists can be difficult, and it can take a really long time to get people appointments. And of course, stigma and discrimination. And I think where that stigma and discrimination really plays out, quite often we have somebody who is, say, on Suboxone, their primary prescriber is gone away, perhaps they've had an emergency or been on leave, the script expires. Any other GP in that clinic could write a script to cover the person until their primary prescriber comes back. Trying to find somebody who will, it's just often a dead end, and it's really difficult for us at PAMS because we've got to find another prescriber or sort of kind of do this dance with the pharmacy. We can't legally ask a pharmacy to dose somebody on an expired script. But, you know, if they kind of offer, we're not really going to argue. It's kind of those sorts of situations. And so many times people are referred, just go to the ED, they'll dose you. I don't think so. Most of the time, EDs won't. And I totally get that. Like, it's difficult. I don't think SafeScript has SafeScript has the script information. Yes, you can tell someone's on treatment, but you can't tell when the person had that last dose. Okay. Does anyone have any questions? I feel like I've been rambling on at you for ages. Okay, we'll just interrupt if you do. We do try and take the learnings that we get from working with pharmacotherapy service users and kind of provide as much advocacy we can at both the national, state, local and other levels. We work with a number of organisations to really achieve this. For example, AVIL, Harm Reduction Australia. We've often been asked to sit on expert advisory groups and committees, research groups. We work very closely with the pharmacotherapy area-based networks, the PAMS that some people may have heard of. We also liaise with the Pharmaceutical Society of Australia, the Victorian branch. We have maintained really good relationships with them, and the RACGP. And of course, doing things like this and conference presentations and that sort of thing. So some of the ways that we could maybe look at improving the pharmacotherapy service system, it is at a point of crisis in Victoria. There is no doubt. We have an incredible demand for treatment, but treatment's really quite hard to access, and really good treatment is hard to access. The Department of Health is embarking on a statewide review or reform of the pharmacotherapy service system in Victoria, which is fantastic and been a reasonable time coming. In terms of what sort of solution we find through that review or reform, my sense is that it's going to have to be multi-pronged. It's not just going to be one thing that will fix the problem. I do think there needs to be some level of a kind of one-stop shop for some consumers, possibly people that are dealing with multiple issues. So, and I guess what I mean by that, there's no place where prescribing and dispensing happens in one place. Turning Point, for example, the Austin Hospital, both of which have a specialist pharmacotherapy service, many years ago also used to have a dispensing service for the people that saw the doctors at those clinics. None of the SPSs dose anymore. And I think that's difficult because we do get people that for whatever reason, at this point right now, it's not working for them to attend community pharmacy. And it's not like that forever. It's just they need a period of time where they don't have to be going into a shop with other customers, that sort of thing. Timely access to addiction medicine specialist consults is something that we need to address. This smart card for dosing is something that I think would be really good. Imagine if you just had a card, you could walk into any pharmacy and get a dose, swipe the card, up comes the photo, the script. It's all linked to SafeScript. Like, why not? Probably money, but anyway. There's been a number of sort of views that possibly moving towards a national system would be good. Every policy is state and territory jurisdictional. So the way that the program operates in each different state and territory is completely different, like very different, with its own set of guidelines and very specific issues as well. I think we definitely need to review the permit system. Given that we've now got SafeScript, there's a number of theories that we might not need to have the permit system for pharmacotherapy treatment. That would make accessing treatment a lot quicker because the prescriber does not have to apply for a permit. Equitable access to all treatment types, I think, is something really important. Mental health, pain management, drug dependence, all the stuff that I've kind of mentioned. It is really difficult for prescribers to make money out of prescribing, and that's because the Medicare rebates have just sort of reduced. There is this triple incentive for bulk bill, and that will help. In terms of cost used to be all community pharmacy dosing fee issues, but I guess it's fair to say in the last couple of years, we have had people contact us at PAMS saying, look, my doctor is no longer bulk billing. I cannot afford, like I'm on a Centrelink benefit. I literally just don't have the money to outlay the $80, the $110. Okay, you get 35, 40 back, but people on really low incomes, you don't have the money to put out. So possibly a specific MBS item that either a general practitioner or a nurse practitioner could utilise if they're prescribing pharmacotherapy may really help in that regard. So one of the things that everybody's probably heard about is the national changes that came in on the 1st of July. Largely, dosing fees are not what they used to be. And this, like, I literally could not believe this had happened. I was so happy. Like, cost is the biggest problem for PAMS service users for the entire time I've been at PAMS, which is over 15 years. I'm a little embarrassed to admit, but it's, you know, people were not able to eat, not able to pay rent, becoming homeless. Like, it was roughly $140, kind of 11 to 15% of an entire Centrelink benefit. People were paying on one medication. Now they're paying $7.30 for 28 doses, and it's just the most awesome improvement. So for people on low incomes, and well, for anyone, pharmacotherapy treatment is now affordable for the first time in community pharmacy. So hallelujah. We used to be able to get 6-month scripts. 84 days is actually the maximum. So it's 1 script and 2 repeats. Script expiry dates and missed doses have all changed a little bit. Getting this information out to the consumer group has been difficult. We're also finding that pharmacies are a lot less likely to continue dosing somebody on an expired script, which I completely understand. There is a really big problem for people who do not have a Medicare card because treatment is doubled, if not tripled, depending on the treatment type for those with no Medicare card. So for refugees and asylum seekers, for example, unfortunately, Suboxone has become the most expensive, and that can be about $586 a month for someone on a reasonably high dose of Suboxone with no Medicare card. And we are desperately trying to address that issue. I mean, I think it was actually just totally overlooked. I don't quite know how that happened, but it seems to be the case. Prison post-release is difficult because prisons don't collect Medicare card numbers. So the scripts that prisons are writing, and this is all sort of in the process of being addressed, but the scripts that prisons are writing are not actually, sometimes not able to be, community pharmacy can't dispense on them because of this sort of issue. One of the good things, though, is that there's a national consistency. So no matter which chemist you go to, the price of pharmacotherapy treatment is going to be the same. From the service provider perspective, pharmacies are guaranteed payment, so they don't have to write off bad debt. A number of pharmacies and prescribers felt that there was very little consultation, and that was unfortunate. It's also the timing of this change is come in the same 6-month period as the 60-day dispense. And probably most of you know about the 60-day dispense. So pharmacies are really worried about their bottom line. They're fearing that they're going to lose money, and they're also fearing that they're going to have to do a lot more work to get the money through this new system. And it is more complicated. There was quite a steep learning curve for both prescribers, who now have to write a script in the volume of medication over 28 days, as opposed to a dose daily for this date to that date. We actually had about 12 pharmacies that were threatening to completely close their program as a result of this change that came in on the 1st of July with the dosing fees. In fact, 8 pharmacies in Victoria have closed their program, which is a bit unfortunate, but at the same time, a number of new pharmacies, probably off the top of my head, maybe 5, 8 new pharmacies have come on board. And that's really good and really encouraging. Pharmacies have said to us that one of the issues is they're struggling to get prescribers to write the scripts correctly. And I think that's it's really frustrating for pharmacies, because if the scripts are not written really correctly, they're not able to dispense them. So that's a big problem for pharmacies. And we try and help with that as much as we can, but there's a limit to what we can do. I had a hospital call me about a week ago, and they said, we're discharging this guy today and he's on methadone, and what do we do? And I said, well, you need to write the script. Like, any doctor from the hospital can write a script for up to 7 days. Give the person our number. We will find a prescriber to take over in the community after the hospital script expires. And they're like, how do we write the script? And there was this frantic thing of me having to send them emails and resources on how to actually write a script. So, but look, I think we're getting there, and by and large, it's a really good thing, these dosing fee changes. Okay, so the role of alcohol and other drug nurses in terms of pharmacotherapy. I feel you probably all know way more about this than me, and I'm really the last person who should be suggesting anything. But I think one of the things that some pharmacotherapy consumers need is a bit of extra support. Now, this is going to depend on whether you're working in a hospital or a community health service, or where you're kind of based. There are things like, getting to that first appointment that can be difficult for some consumers, particularly people in rural and regional areas. Supporting people so that access to treatment stuff, particularly at the beginning, like how to get there, even the travel training, the requirements that some prescribers have. If no photo ID, they won't see you. Organising a photo to take to that first appointment so that you can present to the pharmacy with a certified photo and a valid script. That sort of stuff really helps. One of the biggest things that we're having to tell people on program is you've just got to book that next appointment in advance. If that next appointment is not booked in advance with a lot of the doctors, you ring up when the script's expired, no appointments for 2 weeks, and then the pharmacist is in a really difficult situation, and potentially that consumer won't get dosed. So the advocacy staff supporting people with treatment choice, particularly if you're able to support someone and they want you to come to the first doctor's appointment with them, understanding the consumer perspective, understanding the provider perspective, and really understanding harm reduction. There is such a harm reduction element in pharmacotherapy, and I think sometimes, particularly with the long-acting injectable buprenorphine, which is, to be honest, fairly abstinence-oriented treatment type. I think sometimes the harm reduction element of pharmacotherapy can get a little forgotten. Hospital discharge and prison post-release, and I've touched on both of them. They are really difficult for people, and because they've got that 1 week, and more recently, I think we're going to have this problem with people being released from detention centres as well. So like immigration detention centres, working with people just where they're at, and of course, always feel free to refer to PAMS. We'll help in any way we can. Any nurse that is willing to consider becoming a nurse practitioner and prescribing, go, go, go. The nurse practitioner prescribers have really propped up the prescribing in particularly rural and regional Victoria, and they just, all of them that I've worked with have been absolutely awesome and really have offered such a good service. And to be honest, I mean, no offense to any prescribers, because we've got some amazing prescribers, but many prescribers don't have the time that nurse practitioners can spend with people. And I think that the ability to spend time with people and listen to people really works wonders. So as I said, you know, understanding the system, understanding the stigma and discrimination that not only the consumer experiences, but also many of the service providers as well. Liaising with service providers in the local area. So, you know, if ever you're talking to GPs, encourage them to prescribe. We always need more prescribers, and there are many areas of Victoria where there is just like literally no access to treatment. And that's a real shame, but we are trying to address it. So what I might do is not do the case study and stop and ask if anyone's got any questions. Yes.
Hi, I'm Sharon. I work for GVADS in Shepparton.
Oh, hello.
I have spoken to you on more than one occasion.
This always happens at PAMS. I sit in a room with people and I'm like, I don't know any of you, but yeah.
As you would be aware, Shepparton is, like most rural areas, is exceptionally poorly serviced when it comes to OAT.
Yep.
For 3 years or so, our service provided a completely unfunded OAT service and the administration of LAIB.
Yeah.
With the recent changes, we've had to stop the administration of the LAIB, but thankfully we have an amazing community pharmacy who took that on.
Awesome.
However, prescribing is still the issue. We are still unfunded, but prescribing so that these people can still access treatment. Several years ago, I heard the then chief pharmacist have a real go at GPs for being quite happy to create the problem that you alluded to earlier of people being on prescribed opiates and then suddenly being taken off. And he really lambasted GPs and pharmacists for being happy to create the problem, but very unhappy to do anything about being the solution.
Yeah.
Do you see this getting better, or are services such as the one I work for going to have to continue unfunded work? And we're now not in a position where we can take on any further clients. So there's a whole cohort of people out there who simply are not able to access treatment easily.
I know.
Are we going to be able to help them?
Look, I definitely hope so, and I think that's a big sort of focus of the review, and looking at reform to the system. I mean, you know, like Shepparton is one of the top 3 places on my lobby list for funding, because it's crazy that you guys don't get any funding. It's just it's appalling. It's terrible. and the fact that you've done it for so long is amazing, but it's reached its saturation point, and there is now, as you said, no access to treatment in Shepparton until something kind of gives. But I think it's really about the stigma and discrimination. I mean, I find it can't just be, I think it's lots of things, and that's the trouble, and that's what makes it difficult to address. So when you've got a GP who's been prescribing opioid analgesics for somebody and then says, no, I think the issue is dependence. You've come in too many times early for a script. I won't continue anymore. You need to go and see someone else. Why do you need to go and see someone else? That prescriber should just continue and transfer the person onto Suboxone or LAIB. It shouldn't have to be. I've even had situations where there have been services that will say, we will take the person on, we will get them started on pharmacotherapy, stabilize them, and then send them back to you. There's no training required to prescribe Suboxone, not at all. So it's not like the GP has to go and do anything different. I don't know, Sharon. I don't know how we get this through to GPs.
That's something that we've tried to do.
Yeah. It's really tough, and I actually don't know what the answer is, but I'm really glad you raised it, and I'm really going to try and push that issue as part of the harm reduction. Victoria is involved in the reform process with the Department of Health, and that's something that we've got to address. But at the same time, many places have been trying to address it for years, and we struggle to hit the nail on the head, really. Does anyone have any other questions? Yep.
Oh. Hi, I'm Sally Jeffries from Dual Diagnosis in Eastern Health. I'm a nurse. Over the years, because I've worked at Turning Point as well, we always rang direct line to get a prescriber and the chemist sort of.
Yep.
So do we still continue that? And then if we have issues, refer a client to PAMS? Or do you kind of work together?
Well, we work differently. There's a lot of crossover with the work. So one of the main differences, as I understand it, is that PAMS is funded to do advocacy, whereas Direct Line, I don't think so much does do the advocacy. So Direct Line, I think, and I'm fearful I don't want to speak on behalf of Direct Line or Turning Point, but I think they sort of find out, where do you live? What do you want? That's the closest.
Yeah, that's right.
Whereas we'll take the person on, we'll do this sort of short, in a kind of more short-term solution-focused case management role, work with them. We actually book that first appointment. We follow up with the person after the appointment, make sure it works. We want it to sort of stick, so to speak. And it's the same thing with the pharmacy. Do they have transport? How can you get there? Where are you living? When do you want to start? What treatment type do you want? So I think we work sort of slightly differently. I mean, there's some areas where just ringing Direct Line will get you possibly a slightly faster result. We do have services contact us and say, can you just give me the name of 5 doctors in this area? Well, actually, we can't. It took us 15 years to get a list of prescribers officially, and we can't just give out parts of that list. But we're happy to work with the consumer. We're happy to keep any other staff totally in the loop, work with you all, and really try and sort of get. So I suppose it depends, really.
Yeah. Thanks for that.
Yeah, sorry. Last question.
Oh, I stole her question. I was going to ask that question. Great. Sorry, not your question. I think that's a great question, because I would have, directed people towards Direct Line as well. My question is, what do you do? What do you say for clients who say, I hate my prescriber? And that's you hear that all the time. They only give me 30 seconds. I don't like them. This ties into her question. She's
good.
I've stolen hers, but is it they're so hard to get. You kind of say, better the devil you know. Stick with them. What do you do?
The only thing worse than a methadone program is no methadone
Can
program.
I add to that? I was going to say, as an NRW, or to ask about your point about no training, for prescribing Suboxone.
Yep.
So say we have a client, could we just go with them to their GP and advocate with them with their GP, call DACUS? Like in my head, we're like, oh, we've got to find them a prescriber. It's like they've actually got a GP. Like,
Yep.
is that
Absolutely, you
what, a
could.
thing?
Absolutely, you could. 100%. And if you went, I reckon you would increase the chances significantly. Doesn't mean they'll do it, but I think it would be a lot more likely if you.
If you put it to them, there is actually no training you need to do to prescribe this medication. You can call DACUS.
You can prescribe for, I think it's a bit difficult.
I
Whether
think
it's
it's
up
that
to
they can
5 or
have
up to
5,
10.
yeah.
People with no
10.
training. It's 10. I believe it's 10. Yep. Yeah. It increased to 30 during COVID.
Is that all OAT?
No, just Suboxone.
Oh, just Suboxone.
So the person would have to be willing to have, but just in relation to the, really not getting along well with the prescriber, we do get that quite a bit. And that's one of the issues that we try and address. So we speak to the person like, is there any, what is not working? And we try and see if we could address that through mediation. We can also negotiate treatment plans, which can actually be written and, co-signed documents if that's what is necessary and required. Or it can be a verbal agreement. If we could try and go through that process, or we can just sort of nut out. Usually it comes back to one problem, like something's happened. It's about takeaways, or it's about a dose amount, or it's about additional medications such as benzodiazepines or pregabalin or something like that in conjunction with pharmacotherapy. So trying to resolve the problem and negotiate it and get an agreement between the consumer and the prescriber. And that's a lot what we try and do at PAMS, get that win-win, keeping everybody happy, and then monitoring and following up and providing the support to all parties is so that's what we try and do. So by all means, get them to give us a call. And was there one other question or not? Did you have a question?
If we've got time.
It's
All
not
right,
my
well,
call.
let's squeeze it in.
I just did a quick Google search, and apparently it's 22 grand a year for 4 years to become a pharmacist in Australia. Do you ever advocate or lobby government to lower study fees?
No, that's not something that we've actually ever really done. It's not, to be honest, it's not our sort of direct kind of area of work, but that would be probably the PSA, the Pharmaceutical Society of Australia, might be able to assist there.
We've also done a bit of that, VADA, with our pharmacotherapy advocacy, talk about ease of access into training for pharmacists, doctors and nurses as well.
Yeah, cool.
All right, I might take over with one, just picking up, Sharon, on your comment and noting there was a comment in the chat around the challenges in Shepparton. Some of those challenges are much the same on the peninsula, with maybe even one prescriber on the peninsula who's reluctant to prescribe. So the challenges are statewide. Let me say 2 things. Thank you, Sarah, for your presentation today, but thank you too for your long-standing advocacy in this space. Okay, I won't take 10 minutes to do closing remarks, but about 2 minutes, and they're just thank yous really. I want to thank Indivior for sponsoring our event again today. We really appreciate it. Thank you to Susanna and the team. Thank you to the outstanding presenters today for presenting, and our MCs as well. A special acknowledgement for Julia, who's standing to my left, Trudy and James. James and Julia put the whole program together and did an outstanding job. It was a great program, so well done. If I could ask one favour, please complete the event survey that will be in your inbox soon. And thank you for joining us. There is still some food available for those who are in the room. Thank you to those online for engaging in the chat and for joining us across the day. We really appreciate it. Thank you all, and we'll see you again soon.